Okay.
And so there we are. So we can wait for other people to come. And and we have Dennis. Hello, Dennis. How are you?
Good, great. How are you doing, doctor?
I'm doing great. We're glad you're here.
Hey, I'm glad to be anywhere.
Well said. Well spoken. You have a gift of words.
Uh, I got a million of them. I'm doing it at the Golden Corral every Tuesday night from 8 till 10. Tell your friends and fill up my little tip jar.
Oh, okay. That sounds like a great idea. The Golden Corral.
Yeah.
Look, we're going to hear about central blood pressure and pulse wave velocity in patients scheduled for total joint alloplasty. That sounds very interesting. And we have
I hope
Dr.
you'll be.
Kronsky today.
I hope you'll be as interested after my presentation as you are right now.
Hey, I like your little heart and their little EKG and the scholarly hat there.
Thank you.
That's a very nice touch. We're going to wait for people to get here, so just relax.
Okay, I'm waiting.
Good, thank you. Me too.
Conference now, right? You have a conference now? Yeah. Oh, okay. So I'm not gonna bring her back in.
No.
Okay. All right. They're clean that? Here.
I got it.
You sure?
We're ready for go on. Good morning, Ed. How are you this morning? Good morning, Cheryl. Cheryl, I'm glad you could join us this morning. Ed, I'm glad you could join us this morning.
Yes, thank you, Dr. Harrison.
Good, we're glad to have you here. Good morning, Cheryl.
How are you?
I'm good, yourself?
Great, thank you.
I'm glad you could come join us.
Oh, thank you. Thanks for the invite. I appreciate it.
Great. I think we're going to go ahead and start. We're in just a few minutes.
Okay, I'm ready.
We have the pleasure of having Dr. Konsky here, who his group is the only other group in the world that's interested in cardio orthopedics. And so we are very, very pleased to be able to join each other once a month in this conference. And so his group has been studying blood pressure in patients who are scheduled for total joint alloplasty. And I think they're really onto something because we've done quite a few studies now and have submitted an abstract for the Innovation in Orthopedics meeting coming up for Dr. Gutsky, which is going to be this year in London. And so we've learned a few things too, and it seems like hypertension and left ventricular hypertrophy are extremely important in this disease. So I think that he's on the right track. We'd also like to welcome Bonnie Machado, who just logged in. And so, Bonnie, welcome to our conference. We're glad you could come join us. And you're self-muted right now. And we are actually on the verge of creating a registry, as well as on the verge of reaching 100 patients in our studies. So Dr. Kronsky's group has, I think, evaluated about 200 patients, and so we'll be very interested in what they have to say. And so without further ado, I'm going to let Dr. Kronsky get started. Thank you so much, Bartosz. We really appreciate your dedication to this, especially on Constitution Day in Poland.
Thank you. First of all, it's my pleasure to have the opportunity to present you what we have found out. And at the beginning, I have to say that unfortunately, we didn't manage to go through analyzing all 200 patients, and that's why I'm going to show you the kind of sub-analysis of our group with a focus to central blood pressure and pulse wave velocity in patients scheduled for total joint alloplasty. So at the beginning, we have to keep in mind the fact that the hypertension is very highly prevalent in Poland, and according to big epidemiological studies, we know that the prevalence of hypertension in our country is estimated to be around 30%, which is equivalent to around a few million people. So this seems to be a big epidemiological issue. However, what we know from our analysis, based on 98 patients that we did some time ago, and the results have been previously published in the Polish Journal of Cardiology, we know that the prevalence of arterial hypertension in this group of patients is higher. 50 patients, so 51% of the patients declared to have arterial hypertension at the moment of admission to the hospital. Here we can see the mean blood pressure values based on the ABPM's ambulatory blood pressure monitoring for 24 hours. And here the results are divided for awake and asleep blood pressure. And based on this, we noticed that 1/3 of our patients could be classified as non-deepers. Non-deepers meaning that the blood pressure doesn't fall between 10 to 20% during the night as it should physiologically. And for the time I'm talking, all guidelines are based on peripheral blood pressure. The newest guidelines came from United States of America from 2017, and we all know the new thresholds for hypertension and for normotensive patients. We are also waiting for the new guidelines connected with arterial hypertension from the European Society of Cardiology, and those are about to arrive in August this year, 2018. So we will see what new will be brought to us. However, as for now, also all guidelines are based on peripheral blood pressure. And now it comes a question from me to you, because I have like in technical introduction about non-invasive measurement of central blood pressure. And my question is, do you want me to go through this technical introduction, or do you want me to skip to results?
Perhaps skip to results, and then if we have questions, you can come back.
Okay, so that was pretty big introduction. I'll just say, without this introduction, why do we think the central blood pressure is important? And this is why, because of, according to European Society of Cardiology, there is 70% of overlap in aortic systolic pressure, meaning that 70% patients with high normal blood pressure values had similar values as those with stage 1 hypertension, according to previous guidelines, of course. So we now know that the values have changed. So this is that was one of the reasons that we decided to look at central non-invasive measurement of central blood pressure in patients scheduled for total joint alloplasty, as we know that they are much more likely to have hypertension. We now know the more or less blood pressure, central blood pressure values. We know how different therapies can work on central blood pressure values, and that different hypotensive drugs act differently depending on their effect, even despite the similar action when we look at brachial systolic blood pressure and brachial pulse pressure. We see the difference in the central measurement. So this is important. What do the guidelines say? The guidelines, according to 2013, so the old guidelines say that the measurement of central blood pressure and augmentation index is of great interest. We need more investigation before recommending its routine clinical use. So this is basically what we did. We are investigating more and more patients using central blood pressure. Additionally, in 2015 or 16, we had American Society of Hypertension position paper on blood pressure waveforms in health and disease. And also here, the conclusion was that we need further research to discover, develop, and test drugs or other interventions to selectively reduce central aortic blood pressure. It influences the way we provide our therapy with using less drugs generally, and therefore maybe having less adverse effects from the drugs we use. The second parameter that we get from using measuring central blood pressure is pulse wave velocity, which is an indicator of arterial stiffness, to be like this in the simplest way of saying. So thanks to pulse wave velocity, we know whether the patient has stiff arteries or not, and it is known to be a cardiovascular disease risk factors as well, both of which depend one on each other, pulse wave velocity and central blood pressure. However, they are dependent to some stage, they are not equal. We have proved, it has been proven in previous studies that in general population, in elderly, in diabetics, in hypertensive patients, in patients with chronic kidney disease, pulse wave velocity is showing connection with cardiovascular risk, positive correlation between both of them. Depending on the value, we know that the survival depends on the value of pulse wave velocity, and it also has been proven by lots of meta-analysis. 1 meter per second increase in pulse wave velocity means 14, 15, and 15% increase in total cardiovascular events, cardiovascular mortality, and all-cause mortality, respectively. So when we know that this pulse wave velocity is too high, the cardiovascular incidence rise, cardiovascular mortality, and all-cause mortality as well by 36%, which is very, very much. The conclusion from lots of studies is just measure it, just do it, taking into consideration its non-invasive nature of measurement. Additional increased pulse wave velocity in normotensive patient could predict developing hypertension in the future. So that is something that we are looking at, that even the patients that we are taking care of, if they don't have hypertension yet, we look at the pulse wave velocity, whether they are likely to develop this hypertension in the future. So we are including pulse wave velocity to our total cardiovascular disease risk estimation, because it improves the value of total death risk between 7 to 30%, depending on where do we look at it. Regarding to our study, it is important to notice that it depends how do we measure pulse wave velocity, because if we measure between carotid and radial artery, or between femoral and dorsal artery of the foot, then the pulse wave velocity doesn't bring us really new information. However, what we did, we used carotid femoral pulse wave velocity measurement, and thanks to that we could see indirect correlation between cardiovascular survival and pulse wave velocity value. So the guidelines say as well that this is the gold standard. Another recommendation for simultaneous carotid and femoral artery tonometry. Even despite those guidelines, we don't really know what one value for pulse wave velocity is, and it looks like there is no one good value, like threshold for too high or too low pulse wave velocity, as it depends with whether the patient is normotensive or whether the patient has hypertension and what grade of hypertension. Additionally, pulse wave velocity is increasing with age as the arterial stiffening is becoming and progressing with age. We know that we can look at both of these factors, and the pulse wave velocity is increasing and increasing. We have some mathematical methods, but we have direct measuring, so we don't need to do it. Also, the pulse wave velocity found its place in guidelines from the European Society of Hypertension, because when we look for asymptomatic organ damage, pulse wave velocity more than 10 meters per second would be consistent with asymptomatic organ damage with in hypertensive patients. Again, guidelines say that we the pulse wave velocity measurement should be considered to detect large artery stiffening class 2A and level of evidence B. So it looks like it could be a new surrogate endpoint for cardiovascular disease on one hand. On the other hand, the importance of arterial stiffness as cardiovascular risk factor for future development of new type of drugs. However, let's look at the date of those publications, 2007, 2008. We are 10 years later, and we are still waiting for new evidence and new classes of antihypertensive drugs to appear. So we know that pulse wave velocity is corresponding to the stiffness of the arteries, mainly to the aorta, depending on how do we measure it, and that it is a strong predictor of cardiovascular disease. And death risk. And of course, as I'll show in a minute, it has a clinical utility. So we have different measurement methods. We used applanation tonometry. This is like invasive method that was the same beginning. We use the complier stuff to measure the central blood pressure, which is in accordance with the guidelines, and the same method has been used in epidemiological studies. So we believe that what we see is really can be trusted. What is more, we have evidence that the recorded waveform is the same as measured in the invasive wave using our complier. And now I have short movie to show you how does it look like. It takes 3 minutes, or maybe you are familiar with that and you don't want to see it. What do you think?
We would love to see the movie.
So this is how it looks like. We do it a little bit differently. I'll tell you in a minute. The first thing is, can you hear the voice or not? Not really.
No, I can't hear the voice.
Okay, so I'll tell everything. Can you see the movie right now, just to make it sure?
We can see the movie quite well.
Okay, so the pulse wave velocity is telling us about the arterial stiffness, because depending on the shape of the wave that we can see during the measuring, we can assume whether the arteries are stiff or rather elastic. And additionally, as I mentioned, it found its place in the European Society of Cardiology guidelines when we are looking for asymptomatic organ damage. So that is the first thing. And the second thing is central pressure, central blood pressure, which is different, of course, than the cuff pressure. And the central blood pressure is the one that organs seem to feel. Then they seem to be submitted to, like brain, kidneys, or major arteries. So it seems like it has bigger prognostic value rather than peripheral blood pressure. That here we can see the way it is being performed. Carotid artery and femoral artery to assess central blood pressure, but before that we measure peripheral blood pressure like regularly. We put the information in the system, then we measure the patient, the distance between the places where we put those when we put these things that we can see right now in the movie. So the distance is measured, both carotid and femoral artery, and it takes just a few seconds to see the shape of the wave, and after that we see the results of central blood pressure and pulse wave velocity. Here we can see 10.3, so according to guidelines it's too high, it should be below 10 when we're looking at target organ damage. We can also analyze the shape. It will be shown in a minute. Augmentation index, that is also an important factor. And we can print it. It's not this important. So we have information about arterial stiffness and central pressure at the same time, of course. It takes usually like 5 minutes to do it, and even a technician can do it if there's no doctor to go through this. So now let's look at our results. This is basic group characteristics. We managed to examine 29 patients. We included 29 patients into this sub-study. Here we can see the basic group characteristics. So mainly the patients were elderly. They were a little bit overweight, and usually peripheral systolic blood pressure was too high, 41 with standard deviation of 16.4. It just shows once again that hypertension seems to be a big problem in Poland. We are still trying to improve the treatment. However, let's keep that in mind that this is an average number, so some patients had much higher systolic blood pressure. On the other hand, we see the central systolic blood pressure of 125 with standard deviation of 21 millimeters of mercury. And according to some suggestions, because we can't really say about guidelines according to central blood pressure values, it is regarded as borderline for the hypertension is 125 millimeters of mercury, and when we look at central blood pressure. Later, we have pulse wave velocity at 8.9 meters per second, augmentation index. Also, we did some laboratory testing and general examination, like whether the patient is hip joint, knee joint alloplasty, whether it's statin treated, and so on and so on. So we saw that even despite this value of central blood pressure, normal central blood pressure was found in 30 patients, so less than a half. And on the other hand, raised pulse wave velocity was found in just 8 patients, so 1/3, almost 1/4 maybe, of the studied examination. Later, we looked at our results from many different angles, and this is what we have found out. So the first thing was the comparison of the characteristics of the studied group depending on the operated joint. So we had 17 patients with hip joint alloplasty and 12 patients with knee joint alloplasty. Those groups were rather similar. If you have any questions, of course, do not hesitate to ask and interrupt. We saw that the peripheral systolic blood pressure was a little bit higher in knee joint alloplasty group, however, without statistical significance anywhere in here. Pulse wave velocity was rather higher, like 9.1, 8.6 meters per second. That's the second part of the same analysis. We found that knee joint alloplasty patients who underwent knee joint alloplasty were more likely to be statin treated. It was close to being statistically significant. However, we are aware of the fact that those were just 6 patients and 29 in the whole group. Later, we compared the study group depending on the value of central blood pressure. So we had 16 patients with raised central blood pressure and 13 with normal central blood pressure. Normal meaning below 125 millimeters per second. And what is interesting is that those with raised central blood pressure tended to have higher systolic blood pressure, which seems to be a little bit inconsistent with what we know from bigger randomized trials. However, on the other hand, we can look at it by while remembering this 70% overlap, that sometimes patients who seem to be normotensive while measuring peripheral brachial blood pressure show this hypertension while measuring central blood pressure. So this is like giving us additional information. We have more tools to assess those patients, whether they are hypertensive and whether do they require additional care. Also lower diastolic blood pressure in the group with raised central blood pressure. Pulse wave velocity higher, but statistically insignificant, higher in the group with higher peripheral and normal central blood pressure. Another part of this this analysis, we noticed that patients with normal central blood pressure are more likely to smoke cigarettes, which again is probably due to the small number of studied group. And finally, we compared the studied group depending on the pulse wave velocity, whether the patient had normal pulse wave velocity or whether they had raised pulse wave velocity. And we can see that it was statistically significant that patients with raised pulse wave velocity had higher augmentation index, which is pretty clear because of the connection between those two, without any other differences that could like grab our attention. And another part of this analysis, we had 21 patients with normal and raised, 8 patients with raised. Another part of this analysis, And so what we do believe and what we think is that central blood pressure and pulse wave velocity have its place in everyday practice, and its clinical utility has been proven in several randomized trials. On the other hand, we have orthopedic patients who, as we know from your studies and from our studies, do require additional cardiac care. So we believe that this way of measuring is giving us additional tools to assess the risk during the surgery, and of course after the surgery as well. We believe that this is what modern cardiac approach to orthopedic patient is all about. So I'm very interested now, what is your experience with central blood pressure measurement, non-invasive nature, of course, and what are your thoughts on this presentation? What do you think?
Thank you, Dr. Krosky. Why don't you go ahead now, Dr. Krosky, and show the methodology that we skipped, because that will be interesting as well. So you can go back now and pick up on that, because we're very interested in how you did that.
I mean, this will be like a general introduction about what central blood pressure is, and we have to keep in mind the fact that is the pressure in the ascending aorta, and this is different than the one measured on the arm, the brachial blood pressure. It does not equal central venous pressure, it does not equal pressure in the left ventricle, and it does not equal the pressure in the pulmonary arteries. This is something different. We measure the central blood pressure, meaning pressure in the ascending aorta. It seems to be important because that's the pressure that heart, kidneys, and major arteries do feel, so they are exposed to the central blood pressure rather than to peripheral blood pressure. And it is believed that it's a better indicator of target organ damage caused by hypertension. It has stronger prognostic value than peripheral blood pressure, even though we know that we receive lots of information from peripheral blood pressure, and this is not something revolutionary. It is something to give us a little bit more information, like arterial stiffness and augmentation index and this kind of stuff. So this is the shape of the wave that we see while measuring central blood pressure. You have seen it also on the movie. It's coming from two waves, as we can see, and those waves amplify depending on whether the artery is stiff or whether the artery is elastic. We see the one wave coming from systolic pressure of the aorta and the other one from diastolic pressure in the aorta. We have many information from this shape. Augmentation index, this one is important, comes from augmented pressure by pulse pressure, so this another additional information for us. The question is, why does central blood pressure differ from peripheral blood pressure? And that is because of the diameter of the arteries is changing. We know that peripheral arteries have different flexibility comparing to the central ones, and impedance changes. So we know that there are several bifurcations in the human body while the blood is flowing, and then the blood pressure is also changing. I said that augmentation index is an important factor, and we see that it is connected with pulse wave velocity, age, height, sex, heart rate, blood pressure, and whether the patient is smoking or not. Usually both of them, usually when one of them is raising, the augmentation index is raising as well, with one being different. I mean, the heart rate, when heart rate is raising, the augmentation index drops. We know that this shape is changing, the shape of the wave is changing depending on where do we measure. We're looking at the ascending aorta, so that's more or less the shape of the wave. As I mentioned before, the elastic artery in elastic arteries, those two waves amplify less, so then we have smaller this augmentation index comparing to stiff arteries. where there's less time in here, so there's bigger amplification and bigger augmentation index of those two. This is more or less the shape of the wave in an efficient arterial system. That is what it looks like more or less in between, and that is what we can see in an inefficient arterial system. I talked before about this overlap. We don't know for now what are thresholds for the central blood pressure. We know that it changes with age, and the difference between peripheral and central blood pressure is becoming smaller and smaller with age. For now, we believe that central blood pressure should be 20 millimeters of mercury lower than peripheral blood pressure. We know from different studies that hypotensive therapy can act differently on central blood pressure. With the same reduction of brachial blood pressure, there was different reduction when the authors compared atenolol to amlodipine, and it was statistically significant. So another information about how do hypotensive drugs work. The same was seen when there was a connection between amlodipine and atenolol and amlodipine and valsartan in the other group. So despite the same drop in the peripheral brachial systolic blood pressure and pulse pressure, we saw the differences in the central blood pressure and central pulse pressure. So usually the drugs are lowering central blood pressure. However, we know that the beta blockers may even rise it. However, all of these studies have been done using those older beta blockers. We have some evidence, but it needs to be proven as well, that newer beta blockers like nebivolol or carvedilol, those vasodilatators, also are lowering central systolic pressure. And I talked about the guidelines. I mentioned that using central blood pressure, we can use less antihypertensive drugs, avoiding potentially dangerous side effects. Pulse wave velocity, that's the one I told you. I told you about the values. I told you about the guidelines, why we believe that we should do it, why we should measure it, and how it improves our prognostic value. How do we measure it? What is the gold standard for measuring? Yeah, so I believe that this is it, what we have. What are your thoughts? Do you use non-invasive central blood pressure measurement in your everyday practice or not really?
Yeah, Dr. Krowski, I've certainly seen lots of articles that central blood pressure in many times is superior to peripheral blood pressure, and a lot of urging to give that more practice in clinical settings. I've not had any experience myself, but it looks very interesting, and maybe I should be doing that. What's the pricing on these central blood pressure measurement devices that you buy? Can you tell me what those usually cost?
Well, it was a few years ago that we bought ours, and I'm not sure, to be clear, but from what I can remember, it costed around $10,000–$15,000 to buy this kind of thing. However, we know that when there's more and more producers at the market, the prices will probably fall, and I don't know what are the prices right now. The measurement itself doesn't cost anything, because what we need is a computer that we already have, and this the whole procedure doesn't need anything else. It's just our time to measure it. So we get, after we have tools to measure the central blood pressure, it seems to be pretty easy to do. So I guess that answering to your question, around $10,000–$15,000, I would say.
Let me ask you, did you find that hypertension was just as prevalent among the orthopedic patients as their cohorts in the same age group, or did you find it was different?
Basing on the central blood pressure, right?
That's correct.
Well, we found that it was similar. However, as we saw this here, when we had raised central blood pressure, we had lower peripheral blood pressure. So then it depends, what do we look at, what seems to be more important for us, whether it is central blood pressure or peripheral, because when we have patients with, according to European guidelines, still high normal blood pressure and raised central blood pressure, then comes the question, what should we do? However, usually it's like, what, as far as I am concerned and what I know about central blood pressure, it doesn't bring like something we didn't knew. It is broadening our knowledge, so we can go a little bit deeper and see how the hypertension control is going, or whether this patient whether the patient that we know, we're not sure whether is hypertensive or whether he's not hypertensive, then the central blood pressure measurement can give us an answer. I don't really remember right now what was how many patients. No, there's 16 patients had raised central blood pressure, so that is it. And the hypertension at the beginning was. Oh, I don't got this date. I'm sorry. I don't know what was the prevalence of hypertension at the beginning. I can't remember it right now.
Let me ask you, did you do any correlations with left ventricular hypertrophy on echo?
While performing this study, we were unable to perform an echocardiography in this group of patients, so there was no data to connect and to look at. So we didn't look at left ventricular hypertrophy this time.
Have you had any observations on how patients do when they have their hip or knee replacement in terms of blood pressure control?
Well, in Poland, just like I said, control of arterial hypertension is pretty poor, and usually the patients take their drugs like for 2 years after the diagnosis of the hypertension. So often when they arrive to be scheduled for total joint alloplasty, they require correction as far as as their hypertensive treatment is considered. So usually we have some work to do when we meet the patient. Usually the hypertension is not controlled well. That's what I can say.
I see. Well, that's the same observation we have here in the United States of the patients we see with hypertension. So many of them have left ventricular hypertrophy that's significant, which means that their hypertension clinically has not been well managed to the point where they continue to have thickening of the heart muscle. So most of them are just on one drug, a single drug, and those people then need the addition of a second drug. If we're being scrutinized as to whether they have complications post-surgery over a 90-day period, then we've got to make the decision that we're going to add another drug to their blood pressure treatment, not just perioperatively, but for 90 days post-op to keep them from being readmitted, because we're being graded on readmission to the hospital, not complications while in the hospital.
I see your point, and this is very interesting. And sometimes we also have such a problem that the patients come to our hospital for surgery and they have big distance to cover, and we have to keep in mind the fact that patients scheduled for total joint alloplasty have sometimes problems with traveling. So for us, it is extremely challenging to go through this hypertension therapy through 90 days, because sometimes we just lose a patient right after the surgery, or maybe sometimes the patient is coming for the control to the orthopedics and doesn't always have the opportunity to see the cardiologist to deal with the hypertension or other cardiological issues. So it's very good for you that you have an ability to to meet the patient after these 90 days as well?
Yeah, I don't really see them after 90 days, but if they're readmitted, Medicare tracks that.
This way. Okay, I see. I'm sorry.
And then Medicare tracks it, and then they'll ding the doctors who were involved in the case for a readmission to the hospital, even if it has no relationship to anything that anybody was doing. It looks like it's just arbitrarily random events that occur. Say somebody took 2 blood pressure pills instead of 1 by mistake, and they were admitted to the hospital with a bradycardia and hypotension. That if it's within 90 days, that goes on the record of the orthopedist, and they're responsible for that expense. Or if, say, the primary care doctor was concerned that they weren't adequately treated for their blood pressure and added a second medication, and that results in a admission to the hospital with hypotension and bradycardia, then again, if it's within 90 days, that goes on the record and the expense of the orthopedic surgeons. Isn't that kind of an arbitrary approach? Doesn't seem to make much sense. And there is nothing right now that has to do with whether they're in the hospital for 3 days because of hypertension and they had a couple extra days post-surgery, or whether it's 5 days. Nobody's grading anything that has to do with perioperative blood pressure. So it sort of kind of looks like things are actually just the opposite of what you would think would be a reasonable thing to do. Like,
yeah, it looks like.
And so it looks like we have to get in touch with the primary care doctor and tell them that their blood pressure is still elevated on 1 drug and they have left ventricular hypertrophy, or even get in touch with their cardiologist before discharge, which, I don't think they want to hear those things from somebody else other than their primary care doctor, someone who's only temporarily involved in their care for 2 or 3 days. And so it becomes very difficult to handle. But I appreciate the concept of central blood pressure as opposed to peripheral blood pressure. It's a great point that you make. And in the literature where I see many, many articles, it appears that that's more important to be doing that. And if it only costs you a small amount of money to be able to do that, that would be great. If there was a Medicare code, that would even be better. Right now, we can't get doctors to send patients for 24-hour blood pressure recordings because they think the device is too expensive for the Medicare reimbursement, so they don't do it. So patients are treated based on home blood pressure measurements, which can be sort of all over the place, or based on blood pressure medicines that they only see in the office where there's a lot of white coat syndromes. And so that's very difficult too. But go ahead.
I'm sorry. We are doing as much ABPMs as possible. However, we are not able to go through every patient with ABPM. So we are trying, as you mentioned, as it is a gold standard for hypertension diagnostics. So we are trying to make as much ABPMs as possible, and I hope that someday I'll be able to present you the results of our findings as well. Because I'm sorry, I know that previously I mentioned about those 200 patients, but we didn't have really time to analyze and go through this data to present you today.
Thank you. Hang on just a second, and we're going to show our screen and see if we can give you some information about our group of patients. So just hang on for just a second, and we'll see if we can get that up. Can you see my screen now?
Yes, I can.
Oh, good. So hang on just a second. and we'll get to some of our database. So this is our current database that we've probably increased it to about 100 patients now, but we haven't added those yet. And you can see that hypertension is the sort of purple color. Left ventricular hypertrophy is kind of the brown color. And you can look at these and see that here's a purple, here's a brown, here's a purple, here's a brown, here's a purple, no brown, purple plus brown, purple, no brown. Here's a brown that goes with it. And so you can see that a lot of these patients have left ventricular hypertrophy, which the direct implication is that if they still are LVH, then they haven't been adequately treated for their hypertension. And then occasionally you'll see a patient that has LVH alone, and those patients haven't been diagnosed as having hypertension. So here's one that's LVH alone, no diagnosis of hypertension, newly diagnosed. Here's one LVH, newly diagnosed hypertension. LVH, newly diagnosed hypertension. Here's a hypertension without LVH. And so as we go through these, you can sort of get an idea of a quick survey. And then we go down to the finalness of calculating the data. And you see of the patients that we examined with these 77 cases, 62% had hypertension. 41 of these were inferred. Now, 41 of these were known hypertension, and 7 were inferred by having LVH. And so of those, total 40% had LVH. Of those with hypertension, 58% of the hypertensives had LVH, which implies that they were not adequately treated. So the hypertension, as you know, leads to LVH, which leads to diastolic dysfunction, which leads to left atrial enlargement, which leads to LA fibrosis, which leads to paroxysmal atrial fibrillation, then to chronic atrial fibrillation, and then the risk of cerebral vascular accidents. So you can see by looking at the red, the number of patients that have been shown to have the end stage, which is either paroxysmal atrial fibrillation or chronic atrial fibrillation, as a problem that developed from long-standing high blood pressure developing LVH. And so that's kind of the hypothesis. And then you can see on our group of patients how many of them had a green light in terms of not having much in the way of coronary artery disease, and then just a few who had ischemia, which were marked by the pink. And so that's pretty much a totality of our observations here in terms of coronary artery disease. It didn't seem to be such a bad problem when it was bad. It still didn't seem to be a bad problem, and only those that we think that have ulcerated plaques are going to turn out to be at risk because of activated platelets. And so that sort of concludes what I have in terms of comments. Does anybody have any questions from the general audience? Hang on. And I see no questions from the audience, so we will say thank you so much for an outstanding presentation today, Dr. Krosky.
It was my pleasure.
We look forward to your regular contribution and your regular attendance at our conference. We hope that you can recruit some of your Polish colleagues to join us as well. Dr. Sebastian Schmidt was unavailable today because of a cardio-oncology meeting. And so, but he will be here next time. And we look forward to seeing you next month on the first Thursday of the month.
Well, I believe that today the reason why I'm here alone from Poland is our holiday day, and people are usually spending their time with families. So that is the reason why
Well,
I was allowed today.
you're extraordinary, and we really appreciate your commitment and dedication to come on such a holiday. Thank you so much.
Thank you.
We'll see you next month. Bye-bye.
See you. Bye.
Bye-bye. Bye-bye, Mary Daniels, Ramesh, Cheryl, Dennis, Ed, and Bonnie. Thank you so much for your attendance. Bye-bye.
Yeah, bye. Thank you.
Thank you.